Good evening, and thanks for joining us tonight for WESA's virtual event, COVID-19 Vaccines, Variants, and the Future. I'm Sarah Boden, WESA Health and Science reporter. We are now more than a year into this pandemic, and we are at a critical point. On the one hand, cases are surging, aided by new, more infectious variants of the virus. On the other hand, the nation's vaccine campaign is going, frankly, much faster than I would have anticipated if you had asked me several months ago. And here in Pennsylvania, more than a third of people have received at least one dose of the vaccine. Covering healthcare in Western Pennsylvania is really fun and interesting, as we are the headquarters of two major health systems, which provide both medical and health insurance, and both medical care and health insurance, and we're a hub for many types of scientific research. So I've invited three very knowledgeable and plugged in people from Pittsburgh's medical and research community to give WESA's audience a sense of what's coming next for COVID-19. So our first panelist is Elaine Jenkins. Elaine is a registered nurse and patient advocate who sits on the Pennsylvania Council on Aging. Through her work as project manager for Bethany Community Ministries, she has brought COVID-19 vaccine clinics to a number of senior high-rises in the Pittsburgh area. Elaine's also a member of several community organizations, including Pittsburgh Black Nurses in Action. Next is Amy Crawford-Faucher, who is the vice chair of Allegheny Health Network's primary care institution, as well as the Department of Family Medicine and AHN. She's a graduate of the Medical College of Pennsylvania, which is now known as Drexel University College of Medicine, and is a fellow of the American Academy of Family Physicians. And finally, we have Kevin McCarthy, who is an assistant professor of microbiology and molecular genetics at the University of Pittsburgh's Center for Vaccine Research. Kevin earned his PhD in virology from Harvard in 2014, and his lab here at Pitt specializes in the coevolution of viruses and their hosts. Hi, thank you guys so much for joining.
Thanks for having us.
Kevin, so let's start with you, because Western Pennsylvania and much of the US is well into yet another coronavirus case surge. Today, Allegheny County reported 418 new cases of the coronavirus, and we're now seeing daily case counts at about the level they were in January, if not higher. So we know that the variant B117, also known as the UK variant, is here in Allegheny County, and the CDC actually said that it was the dominant strain of the coronavirus in the US, said that today. So how confidently can we attribute that the rising case numbers of B117 is to cause for this surge that we're experiencing right now?
Sure, it's a great question. I think the data suggests right now, based on the virology, that the virus is slightly more transmissible between people. But you have to take into account also that the surge that happened in the UK happened around the holiday times when people were gathering and seeing each other. And the surges now are happening as we're relaxing our precautions. And quite frankly, we're all tired of the restrictions. You know, I work on viruses, and it's hard saying, no, I don't want to do that, or no, I don't want to go there, or I'd rather just stay home. And so you have these, forces of the virus that is more transmissible, and you have people, rightfully so, that are tired, and you have people who want to get back to normal. And so when you mix those things together, you're going to see increased case counts. So it's this hard thing to crack, and I'm focusing on the virus side of that equation, and epidemiologists and public health people are focusing more on the people side of it.
I think it's really interesting what you just said, that you understand the viruses, you understand the variants, but even you, with all your knowledge, have a hard time staying home, not doing all the things we really want to do right now.
Yeah, we've all missed a year of our lives, really, great milestones and family and friends, and also saying goodbye to loved ones as well, virtually. So,
yeah. How do you think B117 emerged? Was there something unique about the person or host that it mutated in?
So it's a great question. That's something we're looking at, and correlation in this case doesn't necessarily always mean causation. And what I mean is what I'm about to say. So in patients that are immunocompromised or immune impaired, what people have seen are viruses that have evolved around their limited immune systems that have certain mutations that are in common with B117 or the virus B.1.351 that first was identified in South Africa, or the variants that are in Brazil that were identified there by the Brazilian research teams. But we don't know if that's exactly how these viruses that are circulating emerged. We know that they're different. We know that they've acquired a series of mutations, but we don't know if somebody who was impaired really was very sick, obviously, and then transmitted that while they were very sick to somebody else. And so I would say the jury is still out scientifically as to how they emerge, but probably these viruses are evolving in people. Every time they replicate, they make a mutation or a mistake. And very rarely those are beneficial for the virus. And even more rarely, those get passed on to another person. And so the best thing that we can all do, independent of every other factor, is limit viral transmission and limit the chances that the virus has to replicate and acquire a beneficial mutation.
There's a sense that the reason, or maybe not a sense, but some people believe that the reason that the 1918 pandemic ended, sometimes people call this the Spanish flu pandemic, was that the virus mutated in a way that it became less deadly. And the sort of thinking, maybe common wisdom, is that viruses don't want to kill people, viruses just want to live. And so if you kill your host, that's not beneficial for the virus's survival. Do you think this is wishful thinking, or do you think this could happen with the coronavirus?
So I don't know if it's wishful thinking is the right term for it. What you do have from any encounter with a virus is immunity. You're not born with immunity. You acquire that as you age and are exposed to viruses. And so there's a few things that are going on. You have a virus that's changing, and then you have an immune system that's changing as well to meet the viruses that you've seen in your life. I know it's a hypothesis. I don't think there was anything strikingly scary in the 1918 flu. We know its genome. They've actually extracted it from the permafrost in Alaska, and they've sequenced it, and really a tour de force of science. And there's nothing, as somebody who's worked on flu and the relevant proteins for immunity, that strikes me and says, wow, that's it. That's why it was so lethal. And so I think people built up immunity to it over time. And that immunity, even when the virus changes, offers a certain level of protection, just as we're seeing now with the vaccines that are being rolled out for SARS-CoV-2. Even though these variants are concerning, they still are very, very efficacious against severe illness, even if people do get sick. And they're still even protecting against that as well. So I think.
Oh, sorry, go ahead.
So I think that's the big take-home message. And again, limiting viral replication, limiting spread, and getting exposed to the virus through vaccination rather than natural infection also increases the likelihood that you're going to do okay, and everybody around you is going to do okay.
So that kind of leads me to my next question. What are the chances of the virus mutating enough that eventually our vaccines are worthless against them?
Yeah. I don't know, worthless is not the best word, right? I think of it as a continuum of immunity where you're 100%, you will never be infected. And these vaccines are amazing, and you're not there, right? They're 95%, which means 5 people out of 100 maybe get symptomatic illness. And the next level over from that is then, how sick are you going to get? And so they also put the brakes on the disease course. And then you want to not only have people having their daily lives, you also want to keep them then out of a hospital. And again, there's further brakes that are put on that by immunity. And then finally, you want to keep people alive. And so with that, again, even a low level of immunity may be sufficient. We don't have the right answer where everything falls on that spectrum. So will we need a booster, right? That's the real question. I think if you're recording millions of cases around the world every single day, or tens of millions of cases, it's more shots on goal. The virus can at some point acquire enough mutations that make it so your 95% efficacious vaccine is now in the 40 or 50% range. But the good news is that this B1.17 variant is hit pretty well by these vaccines. But it was a wake-up call to all the regulatory processes and to the companies that we may have to reconsider our approach, and we may need to update the vaccine at some point. And because of that, the FDA has figured out exactly what they would want to see in a clinical trial, and companies are planning for that. And even phase 1 trials with some of these variants are beginning as we speak. And so you're trying to stay ahead of the virus using science and using everything that we know. And vaccines offer a tool to do that.
Yeah. So Amy, I want to move over to you because you've had a key role in Allegheny Health Network's vaccine rollout. And right now there is still aggressive demand from people who want to be vaccinated, but that's not always going to be the case. And eventually circumstances are going to switch and there will be more vaccine doses than people who are unvaccinated but want the vaccine. Do we have a sense of when that switch is going to take place?
So I think a lot of that is the crystal ball kind of work that we've been doing for the past year. We have kind of an unofficial thought process, deadline is too strong a word, that says, maybe by Memorial Day, we'll have that crush of folks who are really motivated. These are the ones who are using up all of the online appointments that Elaine, will allude to, and get that crush out of the way. Then I think that there might be a slightly different feel of the tone and the urgency. We don't really know when that's going to happen, but we do get a sense that when we open up our schedules, it's taking hours as opposed to minutes to fill the open spots. So I think that there is this, especially among older people who have gotten, the ones who want to get vaccinated have gotten vaccinated. And as we roll out to a broader population, there are really motivated people. There are people on the other end of the spectrum who are really saying, not right now, not for me. And some people in the gray zone in the middle. So I think we're thinking early summer is where that's going to tip, but that is speculative.
And when that tip happens, I hear different numbers, 70, 85, 75, 80, about where we need to be for herd immunity. Probably not yet, if that's...
I think not yet. We know that for sure. And Kevin can maybe speak to that more, but I think I've heard between 70 and 80%. Now, again, until we immunize children, we're not going to have that across the American population. We can maybe come close for the adults, but not for the total American or US population.
Yeah. I want to actually hop over to Elaine. You mentioned older adults. Most of them have gotten the vaccine who wanted it yet, but I know there are some real structural barriers for a portion of elderly adults. And Elaine, you've been doing some really incredible work with bringing vaccine into senior high rises. You've staged these clinics where you're vaccinating like 50 people, 80 people, sometimes 200 people. And I know actually Amy and Elaine have worked together on this. But Elaine, can you kind of just talk about why some of the folks you serve, they can't go to a Rite Aid or a mass vaccination site?
Yes, thank you, Sarah. There's so many barriers in our community. I say our, meaning the Black and brown community, especially. Some of the barriers is that transportation. We can't go to some of the places that are having vaccination clinics, such as a community center or the stadium or places like that, larger venues. So because of their disabilities, because of their transportation, they have transportation issues. They sometimes don't have the money. They may not have, we talk about technology challenges. They may not have the wherewith to be able to have an Uber or a Lyft because they don't have smartphones. They don't have apps to put them on. They don't have the money to provide it. A lot of times they don't have not only the technology support, but they can't sit on a phone all day and try to get an appointment. So many people have done that. So many of the seniors that I'm servicing have done that, and they've given up. They say, I've been on that phone for 3 hours. I've been on the phone for 4 hours, and I still can't get an appointment. And then they say, well, once I get through somewhere, all the slots are filled, initially. And I've tried myself just to see what this was like. And we had that 211 number that everyone was said to call. So I called it, and it was such a challenge to myself. You call and you listen to a recording, and then you have to press this number and press that number. And so it's been very challenging for the community that I serve. The other thing that's a barrier is not only getting to these sites, but also just the fact that if we look at the social determinants of health and we just concentrate on the health aspect, so many barriers are in our Black and Brown community. Social isolation, I think that Kevin had alluded to that. People are COVID tired, and so many of our seniors have been isolated in their apartments or in their living arrangements because, they are afraid to go out or they haven't been vaccinated. And, that leads to depression, anxiety. It leads to increase in addiction problems. We had several people that told me, well, since you guys are coming in to vaccinate us, I canceled my medical appointment. I said, you did what? I was appalled. They canceled their medical appointment because they felt that the vaccination was so important that they were willing to compromise their medical condition. One lady canceled, she was supposed to have a colonoscopy, and she canceled that. I said, this is just not acceptable. You can't do this. She said, well, I'm more concerned about this vaccination because I want to be out. I want to get around my grandchildren. I haven't seen them in a year. So we hear these kinds of testimonies all the time. And these are some of the barriers that we see. The other thing is that in their living situations, congregate living arrangements, a lot of the community rooms have been closed off because of the isolation. They're not able to socialize with the people that they've known in the apartment buildings. They're not allowed to go into those social spaces because of the CDC guidelines and the COVID. The high rise that we were at today, the manager shared with me, she said, she said, we had 10 COVID. I said, 10 COVID outbreaks? She said, yeah. I said, what does that mean? She said, 10 people died. I said, what? Yes, and this is just one facility. So this really breaks my heart. It really does. And I become very passionate every time I hear a testimony such as the ones that I just gave you.
Amy, you're a family medicine doctor, and Elaine said a couple really interesting things. She talked about isolation, addiction, people putting off important medical procedures like colonoscopies, which people not only did to get the vaccine, but also because they're afraid to leave. So I'm wondering how this pandemic, what sort of, tertiary effects on health you're seeing in your practice.
Yeah, I think that everything Elaine mentioned is absolutely true. We shifted to a lot of telemedicine visits in the height of our surges locally, so that is some sort of contact. But I would say that 99% of my patients of all ages have experienced some sort of adverse mental health outcome. And it ranges. People who've had a history of depression and anxiety in the past, it may have gotten a lot worse. We have heard tragic stories of friends, and family members who have lost their lives, death by suicide, because all this compounds what may have been going on pre-COVID. But especially in elderly, if your source of, maybe you're widowed or divorced, you live alone, and your source of interaction, which is so life and health affirming, is at the senior center or at the library or your volunteer work, and all of that shuts down overnight, then I heard even with people with no history of depression or anxiety in the past talked about, I'm just not motivated to do the things. And they would really experience this as a lack of motivation, which I think probably we've all felt at various points. But it's, I think the older you are and the more prone to isolation anyway, the more deadly it can be. So it's a huge issue. And then you mentioned that people definitely have been putting off other screening tests. They often show up at the hospital sicker because they were so afraid of going to the hospital or going to the doctor that they put things off until it was more severe. So I think we're going to be playing catch up for a couple of years, in terms of regaining the sense of both physical and mental health that this past year has imposed.
Does that sound about right to you? Like a couple of years, Elaine?
At least, or longer. The urgency that I see here is with the vaccinations. At one time it was said that a lot of the African-American, Black and Brown communities did not want the vaccine, or they were afraid or whatever, the mistrust of the government and things like that. So I've heard those things as well. But interesting enough, when we go into the communities, into the high rises and to the apartment buildings, the people are so appreciative for us to come in. They said, if you guys had not come in, we would not be able to get vaccinated. So I hear an urgency with the vaccine distribution. You know, the Black and brown community has the highest mortality, the highest comorbidity. And when you think about those statistics and the people that we're talking about are not being serviced, that's an issue. And they feel the same way. You know, they feel as though, you know, we definitely want the vaccine. We just have so many barriers to access the vaccines.
You know, I recently saw a survey that said that actually vaccine hesitancy is higher among white Americans now than Black Americans, just a little bit higher. So, I mean, it's interesting with vaccine hesitancy. What I find so interesting is that the numbers are really moving in that people are hesitant for a lot of different reasons. And I know you in your work, Elaine, have done a lot of you've had a lot of conversations with people addressing what is holding them back from getting the vaccine. And so what are some of the fears that you're hearing from people?
Well, right now, I'm not hearing too many fears. I'm hearing that they really want the vaccines. You know, we did a lot of health teaching as well. You know, our time did not just start with the COVID vaccines. Our time started last year when we went into these high rises and did the flu clinics, because there was such a push for, if you never got a flu shot in a year, you needed to get it in 2020.
Yeah.
So with that in mind, that was when we started going into the high rises and doing flu clinics. But not only did we do that, but we also provided health teaching. We provided health literacy. We provided information. We did screenings. We did all kind of like surveys. And we asked the questions, when the COVID vaccine becomes available, are you willing to take it, or would you like to take it? So astoundingly, so many people, I'll say at least 85% of the people said yes, you know, because we have the statistics to show that they said yes, they wanted the COVID vaccine. So we transitioned from the flu clinics into COVID in February. And since that time, we've vaccinated over 1,000 people, just going into the various high rises. And so definitely, yes, they don't have too many fears. One of the things that I find is that when I say we, my staff comes in, they are part of our community. They trust us as people, okay? We were born and raised in these communities. We know a lot of people that live in the communities. I'm also the president of the AARP chapter, which is one of the largest chapters here in Pittsburgh. So a lot of the people that we service are my chapter members. So when
Your chapter's in the Hill District.
In the Hill District, right. That's the location. So when they see me or they talk to me and I say something about, okay, well, I had my vaccination, you know, I'm fully vaccinated. And they say, well, what do you think about it? You think I should take it? And I say, well, that's up to you. I'm going to give you the information, but you have to make that decision. You know, I'm not telling anybody what they need to do and not, but I tell them what I've done and what I think. And then I ask them, I say, well, what other alternative do you have?
Yeah. I think that's compelling. Do you want to live in your apartment for another year? I don't.
No.
Amy, I'm sorry, were you going to say something else?
I was going to say, when I say that just stops them in the track. They say, oh, okay, well, I better take this then.
I'm going to start using that line, Elaine. I appreciate that.
I wanted to ask Amy something. So when Elaine said 85%, I'm like, if only that were like the number for the whole entire population. Because I know you deal with like a very, you're the family medicine vice chair of Allegheny Health Network, so that's everyone. When I talk to people who are vaccine hesitant, one of the things I keep hearing is like, we don't know about the long-term consequences because it's so new. And that's true. It's new. So we don't know long-term what the vaccine will do to us besides give us antibodies to keep us safe. But is this like a legit concern? Should people be worried about long-term consequences with this vaccine, especially because so many vaccines don't have long-term consequences?
Right, right. So I don't know whether it's legitimate or not, but people do have that question. And I'm particularly tickled. And I've had people in their 80s ask me about their concern about long-term consequences. And that's really cute and optimistic of them. So I hear a couple of questions about that. I think the answer is we have decades of experience with other vaccines. So that part we know, and we can extrapolate and say, yes, there seems to be no long-term. When you kind of get into a broader conversation about how mRNA vaccines work versus the older ones, and can hopefully reassure some people about how it's also safe. I think you're driving a balance, because yes, this is a newer vaccine. So we don't have 10 years of data that we do for other vaccines. We don't, that's true. But I think that we can use the fact that, again, decades of other vaccine use without long-term effects, and say that, I think that what we also don't know, which is more common, are the long-term effects of COVID. So I think that we always balance that. We don't know. That is true. We don't have decades of experience with this particular vaccine. But we have some experience already with the millions of people who've gotten COVID, and with long haulers and all of that kind of thing. That part we know is a problem. So again, and again, as Elaine said, what's your option? So when people ask when they're hesitant, that tends to be not the biggest barrier, I find.
What's the biggest barrier when it comes to vaccine?
I think that, again, where people are getting their information from different outlets, whether it's social media or friends. And it is interesting. I mean, I've had patients ask me, am I concerned about the microchips in the vaccine bottles? I have heard people ask me, well, what about all of the people dying from the vaccine? And again, where I get my news, I'm not seeing that. The literature is not showing that. And so I think that, those kinds of factoids take on a life of their own, and it's hard to overcome that. So I think it's more of a sociopolitical kind of conversation a lot of times. I do think, as Elaine said, there is in some communities, distrust of government, which is well-founded. And that's true across the spectrum. I wouldn't say it's just Black and brown people, but some of the other folks that are hesitant. And I see a lot of it in young women who are contemplating pregnancy, are pregnant, or are breastfeeding. So those are probably the three main groups.
I'm glad you brought up pregnancy. We actually had a listener question. I'm just scrolling to it right now. So this is from Sue in Robinson Township. She wants to know if it matters at what point a pregnant person gets vaccinated, like first, second, third trimester, especially when it comes to fetal development. And I think she makes a good point. If we don't know if the vaccine is safe yet in children, how do we know it's safe for a pregnant woman who is growing fetus?
Right. It's a good question. Again, and we are extrapolating. We didn't knowingly test the vaccine on pregnant women, but after the fact, you find out that people were pregnant. They didn't know it, and so there have been scores of women around the country and in other countries who have delivered healthy babies since being vaccinated. I think the key thing, and Kevin can probably speak better to the science of this, that the vaccine itself does not cross the placenta, so it can't get into the baby that way. So, and it doesn't get into the nucleus of the kind of the brains of a cell where the DNA is. So it's not going to change the mom's or the baby's genetic code development, anything like that. I think, again, going back to Elaine's brilliant comment, what is your option? What we do know for sure is that women who get COVID disease while pregnant are much more likely to end up in an ICU, on a ventilator, or to die from women their same age and stage who are not pregnant. And that comes with a risk of premature birth for the baby. So, and then most excitingly, it does seem that the vaccine doesn't cross the placenta, but the antibodies seem to. So that could actually, like flu, sorry, I'm losing my microphone, like flu vaccine and whooping cough, pertussis, that it might actually protect the fetus and the baby after they're born.
Kevin, is that anything to add there?
Yeah, well, just going back to the technologies themselves, they're new for vaccines being deployed in this way, but they're not new vaccine concepts. Right. So the adenovirus platforms and the mRNA platforms.
Can you explain quickly what those are quickly?
Sorry, yeah. So Johnson & Johnson uses an adenovirus, and I'll just speak about the ones that have been granted emergency use authorization here. So it uses an adenovirus, and we've chopped out all of the bits of the adenovirus that make you sick and allow the virus to replicate more. And we use that to get the genetic information to make this the spike protein that everybody sees sticking off of the virus surfaces, and this is where protective immunity binds to. Into cells.
Adenoviruses are like cold-like viruses, aren't
Yes.
they?
Yeah. And so, and they chose smartly an adenovirus that most people have never seen, so we'd have no immunity to that either. So to be sure it gets into you and delivers the right genetic instructions. And so that's one way that it works. And then the second one is an mRNA. And so this, what's called the central dogma in biology, is that in the nucleus, in the center of your cell, you have what's called DNA, and that's long-term storage information. And it encodes the instructions to do everything in the cell, but it's almost, like a film from, like a VHS. I'm dating myself, but it doesn't bring on a life of its own. And the messenger and the workhorse and what transmits the data to make the actual proteins like the spike glycoprotein here is mRNA. And so what mRNA vaccines do is they get the mRNA into the cell and deliver a very short-term message that says, make the spike for a little bit, and then it goes away and is erased. So those are the two different platforms we have. And truth be told, getting a new vaccine to market, you have to prove it's safe, you have to prove it's effective, and you have to prove that it, in a normal time, that it's better than anything else that we have. And that's a lofty goal for most of our vaccines. And so they were terrific, and they were on the shelf and being used for things like Ebola or HIV. And they've gone into tens of thousands, if not hundreds of thousands of people in different contexts. So not delivering the instructions for the coronavirus, but maybe for HIV. And they've certainly been used to protect people in Ebola outbreaks. And so we do have a body of knowledge of the safety long-term of these things. So they're not brand new, but they've risen to meet a new threat. And what's really great about it is it allows us, because they're just genetic information, we've learned how to write that genetic code. And so on my computer, I can send an email off to a company and have that genetic code delivered to my lab, precise, over 4,000 letters long without a mistake. And you can put it into these things and actually make a concept for a vaccine nearly overnight.
So you brought up mRNA, and we got another listener question. They say they're concerned about the mRNA that's injected into your bloodstream with the vaccine. What shuts the mRNA off after your cell reads it and makes the spikes? She notes, I don't know if this is true or not, because I'm not a microbiologist, but she says that naturally occurring mRNA comes with control proteins to turn the mRNA off. So does the artificial one have the same mechanism, or do you carry this the rest of your life?
So you certainly won't carry it the rest of your life. They've made some minor modifications to it that allow it to persist a little bit longer, actually, than the message that's in your cells naturally. But like what you brought up, those also have specialized regulators of them that can keep them stable for long periods of time as well. I think the best answer to this is we need to ship these things at dry ice temperature, and we can only thaw them for a finite amount of time, because even in a sterile tube, they rapidly decay. Now in your cell, you have all of these regulatory proteins, and they chew up RNAs very quickly. And so when it gets into a cell, that message is only there for days at most. And not only that, it's going to make that cell produce the spike protein, and that cell is going to have a spike protein on its surface. And the immune system is going to get wise to that and kill that infected cell. So even if it did, which it doesn't, stick around any bit longer, that cell will be destroyed by the immune system. And in doing so, it teaches the immune system to kill more things that look like the coronavirus.
I think something else to point out that's important to understand about vaccines is that we get one dose, and then for the mRNAs, we get a second dose. So it's not like a medication that you're taking once a day. It's not like you're continuing to introduce this foreign thing into your body. It's like kind of a 1 or 2 and done thing.
Yep.
Yeah. Okay. And then also, we were talking a lot about equity with Elaine and Amy, was at the local and state level, but there are less wealthy countries that are still waiting for their vaccine, and they'll probably be waiting 2-3 years. Well, frankly, the US has more doses than it needs right now. We've contracted enough vaccine that we can vaccinate everyone in our country plus. And then a number of other wealthy countries are in a similar position. But if we're not prioritizing vaccinating people in less wealthy nations, what does that mean for global health? Because the pandemic affects everyone on this planet.
So that one's to me to start, or is that?
Yeah.
Okay, so I'd say that that's a question that starts to get a little bit out of just being a microbiologist. But what I can say is I hope that it leads us to reevaluate global health in general. There's probably at least 100,000, if not more, people that die of the measles virus. We have a vaccine that works terrifically against it, and there's not a wherewithal in a system to deliver a virus in the arm of every kid in the world. This is true for a number of other preventable childhood diseases. And so it's not as simple as it is to just drop off a crate from Pfizer or Moderna in a country and expect that we're going to have wonderful coverage. I mean, there's a lot of infrastructure that needs to go into that as well. And I think this is the wake-up call to, realize that we live in a global society. We're more interconnected than ever. And so, obviously we need to share those doses. We can't hoard doses, to infinity. I do hope on the other side of it that our investment in building up the infrastructure to produce billions of doses, so that money that makes an mRNA vaccine more affordable, or that makes the Johnson & Johnson vaccine, takes it from we can do 50,000 doses for Ebola to we can do 1 billion doses for the world. I hope some good comes of that for sharing and distributing those vaccines equitably around the globe.
Elaine, Amy, I saw you guys both nodding your heads. Thoughts?
I think that global health has suffered, but US public health has been decimated over the last 30 years as well. And I think the problems that we're trying to solve is that we want everybody who wants a vaccine to get a vaccine. And that's not just in a 6,000 per day clinic, but in someone's home. And that's where those resource demographics really affect it. I think what we're seeing is that the high rises in the group that Elaine and her group has been working so hard to access are falling down farther down the ladder because the pressures to get the vaccine into as many people as possible, as quickly as possible, is superseding that. So what we're seeing as a microcosm in Pittsburgh is what we're also seeing around the world. So I would love to see us learn from this and reinstitute and reconstitute a robust public health system in this country. So it's not an either or, it's not going into home visits for homebound people or mass events. We actually can accomplish all of this to achieve the goals.
Elaine, where do you think would be a couple good places to start as we think about how we deliver healthcare and how we think about public health going forward?
Well, one of the areas that, like our concentration, myself being a medical professional and nurse, I look at everything globally as well, but I also look at it very microscopically in the certain communities that are being missed. This is my concern. We have a whole generation of people that are being missed. And when I say that the high rises or congregate living situations, I'm also talking about people who have disabilities. I'm talking about homebound people, and they have not been vaccinated. They're starting to, not starting, but they are feeling some type of way. I was very concerned about the long-term or
long-term care.
Yeah, long-term care facilities and the number of people who, had mortality rates. The mortality rates were off the chart. And that was alarming as well. So now we're talking about still in the high rise and the congregate living and the Black and brown communities, it still exists. And, this is an area, and Dr. Amy had mentioned that, an area where we're just not touching. We're not reaching that area. And if we have a team of people who's willing to go into those places, but we can't get the vaccines, then that's a problem. That's a major issue. So they still won't be reached. And the mortality continues to go up. We hear on the TV again today that there's another surge. I think Dr. Boden had mentioned about the surge today. This is the 4th surge that we've had here in Pittsburgh and in the Pennsylvania areas. And so with that in mind, we're expecting more death rates to continue in our Black and brown communities once again. And that's just unacceptable. And I think that I feel as though very strongly that education is very important. You know, we have a lot of people who I think Dr. Amy had mentioned are not being educated on what the reality is of the whole COVID information. Dr. Kevin had mentioned various things about the vaccines. You know, if you don't know about the vaccines, you have many questions concerning it, but your questions are not as, I don't want to say relevant, they're relevant, but they're not conclusive. I mean, we can't say what's going to happen in the next 10 years. We can't say what's going to happen in the next 5 years or even the next month, actually. We just don't have that crystal ball. But we can say that if we have the vaccination, we can work toward herd immunity, then we may have a chance of survival. Right now, that area that I'm talking about in the communities, they don't have that chance because they don't have the vaccines. They're just not made it possible for them. In order to, so we try to stay positive with the people that we're servicing. We try to stay positive with everybody concerning the vaccines and how we're going to get them to them. And we tried to arrange, or we did last week, arranged transportation for 22 residents. That was an all-day job to try to arrange the vaccination for those people. And so if you have a team of people, that's a full-time job, you know, to try to get transportation. We had a person that was an amputee, a double amputee, meaning he had no legs. Both legs had been amputated. And he was very concerned. He said, I just can't get to these places. I just can't do it. So we said, well, we came into his high rise and we were able to be successful enough to at least get him a ride there. He couldn't ambulate too well, but you know, he had a wheelchair that he was able to get to one of the clinics. So these are the things that have to be made available to our communities. And if we're looking at a large scope, and I understand that we want to get as many people vaccinated in a short period of time as you can, but then you have a whole population that's not being serviced. These are the ones that are dying. You know, it's already been noted historically that the Black and Brown community have the highest comorbidities. You have more chance of dying from this COVID disease. You know, I can mention myself. I'm so careful. I couldn't believe that I came up with COVID in November. It was right around Thanksgiving time. And all of a sudden I got sick. I mean, I was so sick, I thought I wasn't going to make it. I thought I was going to just leave here. And so it was nothing but prayer that kept me. You know, a lot of people started praying. My pastor was praying. And I know that it was only prayer and God that kept me here because I was very, very ill. So with that in mind, that's my other passion, why I'm so passionate about people getting vaccines, because there was nothing else. I mean, I didn't have the vaccine in November. It wasn't even on the market in November. So, you know, we didn't have anything available to even treat what I experienced. So they treated everything symptomatically. I was one of the fortunate ones. I was one of the blessed ones who made it because so many other people died from the COVID vaccines. And so when I say that, the inequities continue so despairingly. You know, we are doing a good job, but we're not doing a good job. I mean, I can't say that we're doing such a tremendous job because we still are missing people that need vaccines.
So from what I've observed when it comes to vaccinating the people that are hardest to vaccinate, it's really organizations like yours that like are doing the real, like, I mean, it's like 22 people, like the grand scheme of things, who's going to care about 22 people? Right. So we need like small organizations that really know their community to do this work. And so I'm just wondering, like, for what sorts of resources do you need? Like if you had a wish list, like I don't know, like $150,000 or like so many vaccines, like what do you need to like like scale up and do like your wish list of work?
Our wish list would be $150,000 would be a start. And that way we could go into the communities, we could vaccinate people. We would have a team of people more than myself and my small team to go into the various homes and high rises where that population is being missed. We're partnering, we want to reach out to the various home health agencies because they know the population of people who are unable to get out of their homes. And so we would be able to, my wish list would be that we would be able to have an extensive team, we would be able to at least give them some type of a stipend or something to help them as well. Because it's very expensive to put on these clinics, to provide different transportation. We give lunches to them. We do health information. We go door to door. It's not like a one-shot thing. We do a lot of background things that we do. We go into the high rises twice before a vaccination even takes place. We do a site survey, information that has to be all done, and my team does as much as they can. We have phone calls, Sarah, every single day asking us, can you come to our building? Can you come to our place? We can't get out every single day. I got a call yesterday. They tell me the address, they tell me the residence, they say, can you come to our place? We haven't been vaccinated. No one has come. No one has reached out to us. And it just breaks my heart. It really does, because we're just not reaching that community.
Amy, you're with a very large health system, and not to put you on the spot too much, but and you're not, I know you're tasked with vaccinating a lot of people. So I'm curious to hear how you like weigh like the needs of like really marginalized people and also like the pressure to get lots of shots in lots of arms.
Yeah, the conflict is real. There's no question. Because, the more people you vaccinate, the closer you get to herd immunity faster. So there is that. But again, everything that Elaine has said is also so very true. And I want to do it. I want to do it all, And so what we are starting to see both at the state and county level are, at least the state is now looking at homebound people on their Medicaid panels. So that's a statewide process, starting to look at that list and then figuring out how do you go into that. They're trying to look at this on a larger scale, what Elaine's group has been doing all along. If Elaine, her group just needs vaccine. I mean, that's been the biggest barrier, I would think, Elaine. You guys would make it work with a shoestring if you had the vaccine. So I think that's the piece of it. For me, it's staffing. I am just wishing for the day when J&J becomes widely, I want us to be bathed in Johnson & Johnson vaccine, because then a lot of these barriers go away, because then
it's one shot.
It's one shot that doesn't need a pharmacist to reconstitute it and draw it up. So literally with J&J, I could grab some medical students and some nursing students and talk to Elaine, and we could just go door to door one time. Right now, the work we did with the high rises, it's 2 doses, it's 2 separate events, 3 to 4 weeks apart. And so you have to, that cuts down the number of new people you can access with the same number of people. So I do think that shift we talked about early on in the hour about moving away from mass events and focusing more on the harder to reach, either decision-making wise or physically, is going to become more prevalent in the next couple of months. And I can't wait for it to happen.
Oh, sorry, were you going to say something, Elaine?
I was just saying that the 1 dose is excellent. I would love to have J&J's 1 dose vaccine made available. We could just go. And I was thinking about something like a mobile unit, and we can go like door to door and vaccinate quite a few people who could not get out to the larger venues. And, they would get their vaccinations as well. So a mobile unit with the J&J shot, we're good to go.
Kevin, so the J&J is like, by the way, J&J is a Wisconsin company. I grew up in Wisconsin, so very proud of J&J. But Kevin, is there something about the fact that it's a one shot and the fact that it's not super sensitive to temperature? What makes it so difficult to have more vaccines that like hit these like very important logistical Marks. And while you answer that, I need to turn on my light because it's getting dark. So start talking and I'm going to turn on my light.
All right, well, yell if I go off the rails because I'm not sure if I understood the question fully. But so basically, the question is, can you say it again?
Yeah, sure. The question is, what about, why don't we have more vaccines that are just one shot and that aren't so sensitive to temperature?
Okay, sure. So what we talked about before, that the mRNAs are unstable, and so that's the Moderna and the Pfizer BioNTech vaccines. So those rapidly degrade. That's why you need the ultra cold storage for those. The fact that you're delivering the Johnson & Johnson vaccine wrapped up in a viral shell, it protects that information for much longer. And so that virus is made to replicate in your nose just like a common cold virus, and they've taken everything out that'll make you sick. I just want to reiterate that. But that virus has evolved protection and to keep its genetic material safe at 37 degrees Celsius, which is how scientists talk, and at room temperature, for long periods of time while it's sitting there until somebody touches something and then touches their face. And so basically the scientists leveraged this nature and feature of a virus to help us. And so that's why it's so much easier to distribute, doesn't need the cold. And I know production is ramping up. So it's coming.
I'm sorry. I was going to say, Kevin, isn't the Moderna and the Pfizer a 6-hour window?
For a thawed vial? Yeah, I think the FDA just announced that they're extending that time period based on new data that have come in, which will help people a lot. I also did want to double back. Elaine, what is it that somebody like me can do to help organizations like you? Is it donations? Is it to call the mayor? Is it to call the public health office and advocate for people on your behalf?
Everything you just mentioned, Kevin, would be appreciative. Anything you can do would be helpful. Yes. Donations is always welcome. We definitely need that. We need to hire more staff. We need to have more people available. I have a staff of about 20 some odd nurses that mostly all of them do work. And so what I have to do is plug them into each clinic that we have set up according to their availability, and we do give them a stipend as well for their time and service. And there are some that do not want anything. They just want to donate their time and volunteer. So Kevin, yes, if you can give me your contact information, I'm sure we can find something for you to do.
Sure. Well, yeah, I would love to be. I mean, I'm sitting here in a lab building, right? And I'm very isolated from a pandemic. And, our research can help at a distance, but, people really do need help.
Yes.
So yes, we will connect.
Okay, great. That sounds good. So we're going to, good.
Cool. So we just have a little time left, and a lot of the questions that were submitted were about activities people can safely do after they are fully vaccinated. All three of you are fully vaccinated, so I'm going to list off a series of activities that have been considered unsafe for most of the pandemic. So when I list an activity, if you feel safe doing that activity, raise your hand, or you can go like this a little bit or shake your head, but just non-verbally communicate what you would feel safe doing. But if there's like a caveat that, you have to explain a little bit, feel free to speak up. Kevin, I know that you live with an immunocompromised person, so that's something that you have to consider when doing an activity. So the first one is singing in a group of people, like a choir practice. Would anyone feel safe doing that at this point? Nobody would feel safe. What about if you were singing outside?
Maybe. That's better. Yeah, exactly.
No one wants to hear me sing.
Hosting an inside dinner party with other vaccinated people from several different households.
I could probably do that in my home because I have a pretty large home, but I would still maintain the distances. Yes, I would definitely do that. And my husband and I did go to a dinner party with some other people. There were 5 of us total, so it wasn't a lot. And we did maintain our distances as well as that. Yeah, we only took our mask off to eat.
I think that if you're all fully vaccinated and you're still, that sort of small gathering feels okay, but I think you're right. Where's that line between the crush of 30 people in a house? Because we know that even if you're fully vaccinated, it's not 100%, and the virus is still around.
Yeah, what is a small dinner party? Is it 10
Right.
people? Is it 4 people?
Exactly.
Eat in a restaurant.
Inside or outside?
Both. Inside first. Would you eat inside? No.
Not quite yet. Mm-mm.
Outside?
Well,
I would do outside.
The one restaurant that I probably would eat at it's down in Oakmont,
Mhm.
and it's a huge place. I mean, it's huge. So all the tables are like at least 10 feet apart. It's huge. It's really spacious, and they have a lot of air going through. So I probably would eat there because I feel more safer there,
Mhm.
because they have a lot of ventilation here. They have a whole side that's open as well. So I could eat there. But my inside eating would be very limited
Mhm.
at this time.
Go to the gym wearing a mask. No? Shake hands. Oh, and you're about to say something.
No, I've gone to my gym once in the past year, and that was a few weeks ago, and I wore a mask and it was almost empty, and I still felt weird about it. But part of me, honestly, is I think that risk was very low. I think the question is that slippery slope, because even if the gym says masks required, and then you walk in and the few people around you are not wearing masks, then you kind of go, So I do feel a responsibility as a physician who's been spouting, kind of trying to walk the talk for the last year, that I have to continue to walk the talk and be really careful.
Yeah. Fly in a plane with a mask.
Well, when they said on the planes that they're not going to have the middle seat, the middle seat can be filled now. I was thinking about it, but now I'm kind of like, I better wait a while. I think that they're filling the middle seats again.
I think it depends. I mean, again, how do you know this? You don't know what the community spread prevalence is in a group of people on a plane. You can make that you can figure that out for the town you live in, but not if you're on a plane with other people. I surely hope that I feel comfortable by summer, because we have a family wedding that we would really all like to go to, which requires a couple of flights. But I'm
my next question is about weddings. Who feels comfortable going to an indoor wedding right now?
I wouldn't do an indoor wedding.
Outdoor wedding.
I would do an outdoor wedding.
Kevin, Elaine? No?
Not right now. I have to say, with all of this, though, I'm basing this off of 17 or 18% of people being fully vaccinated.
Mm-hmm.
Right.
And so that's a sliding scale that I'm using for my own risk calculation here.
Mm-hmm.
If we talk 65, 70% of people, or that the people you're interacting with in any one of these situations is likely vaccinated, and we've brought viral transmission to a lower level. Right now, we're in a surge. I think that changes my own risk assessment of a situation, and probably for Elaine and Amy as well.
That's a really good way of putting it. You're absolutely right. And I love seeing these pictures. No, I don't love it. It's terrifying, on social media about people's weddings, and it's great. They're in the church and everyone's facing forward and they're all wearing masks, and you're sitting far apart. You're like, okay, well done. And then you see pictures from the reception later where everyone's dancing with no masks, and so I think that you kind of view a situation. I might say, sure, I'll go to the wedding, but I'm not going to stick around and I'm not going to dance or something like that if it were outside.
And I think your point, though, that maybe this summer things will be different because a lot more people will be vaccinated.
We're heading in that direction. We clearly have ramped up in a way that we had a hard time visualizing a couple of months ago. So that's been positive for sure.
So we got to wrap this up, but I kind of on the positive side, I'm wondering, what is one activity you guys have allowed yourselves to enjoy now that you are fully vaccinated? If there's one freedom that you're allowing yourself because you have this protection.
We went to visit my father-in-law and my mother for the Easter weekend, and they are both been fully vaccinated, and my husband is also, mostly vaccinated. So we felt safe doing that, which we had not done in months, inside their houses. Yeah.
Cool. What'd you eat?
I don't even remember, to be honest, because seeing them was so special that the food was secondary.
Elaine, Kevin, what's one thing that you've each been able to do now that you're vaccinated?
Oh, Elaine, please go ahead.
Well, I haven't done anything I'm thinking this week to go to church because our church is open. So I'm thinking this weekend, this Sunday, I should be able to go to church. I'm still going to do the distancing. I'm still going to do the mask wearing. I'm still going to do everything, sanitizer, all that I did before. But yes, that's going to be one thing that I will be trying to do.
Great, Kevin.
So I get to see my parents this weekend. So my parents have fully been vaccinated, and I'm looking forward to seeing them because it's been since a lull in between everything in the middle of the summer. And even then when we saw them, it was socially distanced. So being inside and relaxed with my family.
Awesome. That sounds wonderful. Well, you guys, the hour went real fast. Had a lovely conversation. Thank you so much for joining me tonight. I hope we can do this again.
Thank you so much for the opportunity. It was great chatting with all of you.
Yes, thank you so much as well. Can I leave you with one little quote that I always used to say when I worked actively? And that is, people never care how much you know until they know how much you care.
I agree. Yeah. Awesome. Well, have a good night, everyone.
Thanks very much. Good night.
Okay, good night.
We are